Welcome, those of us who are here right now. This is our RFH University Education's monthly session. This month, we are really excited to have members of our telehealth clinical evals program with us today, particularly Kim Porras and Amber McKenzie, who are going to be presenting today. We're very excited to have them. They're going to be going through a lot of details about not only mobility assessments, but other environmental factors that can really influence care and the way that we see them. Now, we know that our program here at Restore First Health is a mobile program. We are in the homes. We see environmental factors that can really make a difference about how people may fall, may get injured, and things that we can do ourselves to help prevent it from a clinical perspective. So we're really excited to have them both here. Kim has been a healthcare leader for over 20 years experience here in clinical and operations, and she has been working with TCE. Kim, it's been over a year now, right? Has it been over a year?
Yeah.
Mm-hmm. And really shaping this program to be what it is today. And we're really happy to have her to be able to explain sort of the depth of the program and how it integrates with all of us, as well as all of those of you who might be joining us that are not Restore First Health, that are our outside partners. We're happy to welcome you here today and learn more about it too. Amber is a board certified nurse practitioner, and she specializes in mobility, acute care, family medicine, and pediatric emergency medicine as well. She's licensed in 23 states, so she certainly has a lot to lend around the country. And she really is committed to delivering, accessible, patient-centered care. And so we're thrilled to have them both. I'm going to move over to the actual presentation here. Just let me take the rest of the people who are trying to get in, and then I'm going to move over to presentation. Okay. Here we go. All right. Can everyone see the slides? Wonderful. Thank you so much. All right. I am going to kick it off to Kim to get us started.
Awesome. All right. Thank you so much, Lori. And thank you guys for joining us. It's a good group today. If you can go to the next slide, we appreciate the introduction. As Lori mentioned, we are part of the Restore First Health family and have been working in this space for the last year in a very, very meaningful way in order to improve what you see on the screen right now. So per the CDC, almost 29% of adults live with a disability. A lot of these stats, you guys, are not going to be new to you because you are working with patients every single day. But it's interesting to hear, and it was interesting for me to hear and see that 41 million adults face walking challenges. So just think about that for a second. 41 people in the US face these challenges, and 6.8 million of those adults use use mobility support devices. That doesn't mean that those 40, there's so many of those 41 million that need to be in these devices. We had a conversation at the beginning of this call, and we're just talking through how important these complex devices are. And that's how we got our start with TCE. We have, because of what you see on the screen and the statistics here, we have been able to expand, and we'll talk a little bit more about it in later slides, but we've been able to expand our offering so that not just patients who need the complex devices are getting the support. So the big, bottom right-hand corner of your screen there, we mentioned this huge number of almost $20 billion, and that is how much is spent on mobility-related care. So, a lot of times as clinicians and as clinical organizations, money is not what we want to talk about. However, that money gets translated to patients many times, right? So those $20 billion, some of those costs get sent over to the patient. And so we want to do our best to reduce that as much as possible. You can go to the next slide. So the, 1 in 6 adults has missed their annual checkup, 1 in 6 adults with disabilities. Now, I was actually surprised at that because I thought more seniors would be missing their checkups. But if you think about it, people age 45 to 64 years old many are still working, and they're trying to ensure that through their disability, right, they can make a living, but they're missing out on their annual wellness visits. We have seniors who are also missing out on their, annual checkups. 1 in 17 seniors miss out on that. And the biggest barrier, and I don't know if you guys are surprised by this or not, but the biggest barrier to access of healthcare is transportation, right? So imagine some of these patients, paraplegics, quadriplegics, if they're in devices, or those that just have mobility issues, coordinating transportation is pretty difficult. And so 35 million seniors in the US have reported access or transportation issue access. So, all of these stats, again, you guys know these things. I think you may not have these numbers memorized, but just getting an idea of how big this problem is and how many adults have issues, just healthcare barriers, I'd say. You can go to the next slide. And so because of that, telehealth clinical evals historically has been an organization that it essentially takes the mobility evaluation or a complex rehab evaluation, and it cuts the time in half or more. All right. And so what we do is these patients that are in need of complex rehab previously, and now we're doing these evals for all patients with mobility issues. But what we do is we take, these 2 separate visits. So excuse me, historically, it's a face-to-face physician visit that the patient has to go to their PCP and have this face-to-face evaluation completed. And then they've got to go to a therapist, an occupational therapist or a physical therapist, and have a separate visit as well. And I see a couple of head nods in the audience because I think you all deal with that regularly. Some of you do. So what we've done at TCE is taken both visits and combined them into one. And so we have on a telehealth platform, we have both the physician or the advanced provider with a occupational therapist or a physical therapist. At TCE, we have employed thus far all occupational therapists, but we are not opposed to hiring physical therapists, and I'm sure we will in the future. That visit takes about 45 minutes, 30 to 45 minutes, but they're all scheduled for 45 minutes. And during this visit, you have both the APP, the advanced practice provider, or the physician, and the therapist coordinating care along with the ATP. So for those of you who are not familiar with what an ATP is, many of our partners, our partners employ assistive technology professionals. And what these folks do, these folks are trained to understand this complex equipment. So you've got 3 team members on a call with the patient in a telehealth visit, coordinating what equipment is best for the patient while they're evaluating the patient. So you've got less denials for sure from insurance claims for our referral partners. We also are turning around our reports in a very short amount of time. So our goal is, and I think the industry standard is like a week to 2 weeks for these notes. But we have partners who've waited months for PCPs to sign and document or adjust clinical notes. So we love our PCP partners. We work with them regularly. We do not steal patients from our PCP partners, but we help them because many of them are not trained the way that Amber has been trained and our other clinicians have been trained specifically in this space for complex rehab. So it's a shorter, it's 2 visits in one. We're getting reports out to our partners quickly, and then patients are happy. Patients, at the end of the day, I think the majority of us are in healthcare to help patients and to do the right thing, right? And so when patients are waiting 9 months to a year for their equipment, we're able to cut that time in a lot less. We had an example recently where things were turned around in 1 month. So 4 weeks is a big difference compared to 1 year. You can go to the next slide. I'm going to hand it over to Amber, and she's going to run through what is a mobility assessment and a few other clinical areas of our care.
Thank you. And as Kim mentioned, with millions of seniors experiencing barriers to seeking healthcare, it's no wonder that the cost related to falls has reached almost $20 billion. Sorry, there we go. At Telehealth Clinical eVals, we do provide basic mobility assessments in the comfort of a patient's home to help identify risks and prevent falls and potentially serious injuries that can result from those falls. We accomplish 3 goals through these assessments: determining the patient's ability to safely perform their mobility-related activities of daily living, and in a reasonable time frame, including their ability to ambulate, to transfer, and to use any available assistive devices that they have safely. Secondly, it supports our clinical decisions, such as referring to needed therapy services, ordering assistive devices, and referring back to primary care for any ongoing or unmet specialty care needs. And then thirdly, assessing their safety with mobility, with or without an assistive device, their balance and their endurance to further guide necessary interventions and improve both their safety and their function. We can go to the next. Key clinical components of these types of assessments include the gait analysis, transfer mechanics, balance, strength and coordination, and cardiopulmonary endurance, as well as other factors which may impair mobility, such as medications that they're taking and environmental challenges. Outcomes, as mentioned here, include recommendations for a mobility aid, such as a cane or a walker, or even to recommend manual or a powered mobility device, which might transition that patient from a basic mobility assessment to a complex rehab technology assessment, which we'll talk about soon. As with any visit, it's really important, that we're treating the whole patient so that we can identify other conditions or risk factors that are present which warrant early intervention. So think about presence of things like pressure ulcers or other skin conditions, lymphedema, which can dramatically impact a patient's mobility, and other environmental fall risks or care coordination needs. We can go to the next. So complex rehab evaluations include many of the same components that we just discussed with gait, balance, strength, and endurance, but are focused really on evaluating the patient's need for complex rehab technology, such as specialty manual or power wheelchairs, which are indicated when standard mobility devices won't meet the patient's specialized medical or functional needs. Patients needing these types of evaluations and this complex rehab technology often experience delays in getting the necessary equipment. Here at TCE, our in-home team-based evaluations are designed to overcome those barriers, which can contribute to these delays. We use validated objective functional testing, such as timed up and goes, chair sit to stands, and those types of tools to identify and support justification for medical necessity, including the device selection, custom seating and positioning needs, and specialized needs for programming, and to provide independence with mobility within that device. We can continue. So the leading cause of injury risk in older adults is falls, and as such, we've expanded our services here at TCE to include those basic mobility evaluations that we just discussed, to identify and provide interventions early and to reduce falls, which again is the leading cause of injury. Thank you. When we look at these fall categories, I really want to focus on the top 3 with accidents and environmental conditions, gait, balance, and weakness deficits, and dizziness and vertigo. And so our evaluations are really going to focus on identifying patient-specific risks and helping our patients overcome these risks. We can talk through that during the evaluation to be able to see environmental conditions, watch that patient use things like the furniture or the walls as they're attempting to ambulate throughout their home. We can look for throw rugs and clutter within the home and help to kind of guide our patients on how to open up those spaces to improve their safety. You can continue. So when we look at this slide, we see that the strongest overall contributor to falls stems from gait, balance, and muscle weakness disorders. Patients with neurologic conditions such as stroke, Parkinson's, multiple sclerosis, and ALS commonly experience progression of their disease and worsening of their mobility challenges over time. The earlier we're able to intervene with these patients, the better able we are to reduce their fall risk and avoid serious injuries. Medication-related falls, if you look at the fourth line down, is the number one modifiable medical cause of falls requiring care. During our examinations or evaluations, we thoroughly examine our patients' list of medications and work to identify opportunities to reduce polypharmacy, to educate patients and their families about those high-risk medications, and to determine whether they're taking it at a time of day that could increase their risk, and then help to direct them back to their primary care to determine whether adjustments can be made in their medication regimen. We can continue. I'm going to hand you back off to Kim now.
So you guys, we continue to harp on this 19.8 billion with a B dollar number, right? All of us, again, I go back to, yes, we're in healthcare to take care of patients, but these costs affect how our government, right, healthcare is run. And the goal is to reduce that cost if at all possible, not only for us as organizations, but as for patients in general. So as you go down this list, right, I'll first off, I think that red arrow is pointing you to the whopping number of $7.2 billion. And that is the estimated annual inpatient cost for fall injuries among seniors, right? So that's the biggest bulk of this healthcare spend, acute care spend. Now, depending on what organization you're in, right, whether you're an RFH team member or you're from an outside organization joining us, we all have a commitment to patient care and to ensuring that patients are cared for in the right manner at the right place, right? And so as we're looking at these numbers, I know that in other organizations, whether they've been organizations that I partner with or those that I've worked with previously, we're all looking at how to reduce unnecessary ER visits that turn into inpatient visits, right? So that $17.2 billion is why we're going to get into a bit more of our mobility evals here in a bit. But the other number before we move on that I want to touch on is 2.5 billion. Again, billion with a B is the estimated annual ED spent for fall injuries. So the patient presents to the ER, right? My experience, and those of you who've been in healthcare a while, the majority of seniors end up getting admitted for at least a 3-day stay, right? So if you think about falls that are easily prevented, and Amber will get into some of those here in a bit, we can make a huge difference just together, those on this call, in reducing our annual healthcare spend, right? Our acute care spend specifically. It feels as though this 17.2 billion is such a huge number, we can't make a dent, but there are little simple changes that can be made in order for us to reduce that, right? So just keep that $19.8 billion number in the back of your mind, because I was shocked when I saw that. You can go to the next slide. So $19.8 billion is why we have decided at TCE, and in our with our RFH family, we've decided to begin a mobility and falls risk assessment program. And so we have, and there's several reasons. The 6 on the screen, right? The first is to reduce fall related visits. So I mentioned before the number of patients that appear, in the ER for falls or near falls and concerns because for those near falls. So those resulted in emergency department visits, which result in inpatient visits. The second reason is we can improve patients' functional mobility, right? So how can we not only ensure that patients have proper devices, right? So they may not be appropriate for a complex rehab chair, right? But they may be appropriate for, they may need a walker, and just getting them comfortable enough to be able to say, you know what, I do need a walker. They don't necessarily need a clinician like Amber to say that, or a clinician like one of you to say that, but it's helpful to get patients there. And, I always use the example, my sister is an engineer, but when it comes to healthcare terms, she is not very bright at all. So all of the engineer smarts go out the window when we talk healthcare. And this is the case for a lot of your patients, right? So that number 2 is just trying to enhance safety and mobility for our high risk patients. And the majority of our patients, I think for all of us, are seniors, 65 and older. We want to address mobility device gaps, the third reason we created this program. So there are quite a few patients that we do see and treat at TCE that have a device. They're in a wheelchair, but it's not appropriate for them, or they continue to get wounds or sores. And I see some head nods in the audience, so thank you for that, because you do understand, and you are dealing with it yourself, right? But we are wanting to address those mobility gaps so that we're reducing those sores for patients. And obviously our partners at Restore First Health assist with patients who develop these wounds for being, when they're in the wrong chair. So we can easily, in a quick eval, adjust what, the type of chair, or add on some things that maybe haven't been added on, and that poor patient has been struggling with an out-of-date chair for quite some time. The fourth is reduced care avoidance. So we are doing these visits from a telehealth, for a telehealth visit. So these patients are not having to go out. They already have issues with transportation. We're able to come into their home and perform that evaluation with less coordination needed on their end. I've already mentioned the ROI, right? That $19.8 billion amount. And then ensuring that seniors can age in place. I think all of our organizations talk about ensuring that patients are aging in place. My grandparents are 93 and 90 years old, and they are really stubborn and want to be able to age in their home, right? And live comfortably without anybody in their business, right? And so this, ensuring that they have the appropriate equipment for their home will allow them to live comfortably and be able to age in place. So you can go to the next slide, Lori. I'll hand it over to Amber.
I don't want to take this the wrong direction, but something you said, Kim, about that seeming like an insurmountable number reminded me. I had a patient who once, and actually a family member who was a patient, who gave me a necklace that has starfish on it and told me this story of the starfish. And there was a man who was walking along the beach and saw this little boy picking up a starfish and flinging it out into the water. And there were just millions of starfish along this beach. And the old man walked up to the little kid and he said, "What are you doing? Like, this is wasted effort." He said, "You're never going to be able to save all of these starfish." And the little boy just reached down and picked up the next one and flung that one out. And he said, "Yeah, but I saved that one." And so I think that's really kind of what we're here for in healthcare, is to make a difference in one patient life at a time. And, not like the number it feels insurmountable. We're not focusing on the number. We're just focusing on each individual patient. I think a lot of times our patients don't think that they need the assistive device, or it feels like we're actually taking away their independence. And so reframing our conversations that we have with them of how adding a device actually improves their independence can really change their willingness to accept the additional assistance and help to keep them safe long term. So I'll take it back to the slides. Thank you. So how best can you identify a patient who may benefit from a mobility assessment? So if you're with a patient and the patient presents with observable mobility impairments, and you just kind of think to yourself, you have the hairs on the back of your neck stand up, and you think, man, it's just a matter of time before they fall. That would be a good time to get us involved. Anything that kind of prevents the patient from completing those activities of daily living in a safe or timely manner, or they're relying on other people to be able to assist with activities that they might be able to do on their own were they to have that device. Patients who have gait changes, they're shuffling steps, they're very slow, or they're very pensive with their steps. They're taking their time to make sure they get that foot on the floor. Patients who have neurologic, orthopedic, and cardiopulmonary conditions, such as Parkinson's and others that we discussed earlier, osteoarthritis, rheumatoid arthritis, and other orthopedic conditions resulting in joint deformities or pain, and conditions such as COPD or congestive heart failure, which can severely impair a patient's functional endurance. So not necessarily that they're not able to do it, they just may need to take several breaks and break up a task that you and I might be able to finish in 10 to 15 minutes, and they're doing it over a period of hours or days. Patients who have experienced a functional decline after a hospitalization, an accident, or an injury. Patients who have other conditions such as active pressure injuries or lymphedema, which can contribute to and may actually indicate an early need for fall risk intervention. And your patients who can express a concern or fear of falling, if they think they're going to fall or they're worried that they're going to fall, that's a really good predictive indicator that their risk is high. If they're holding on to walls or furniture, as we talked about earlier, to assist them with ambulation, or they require any equipment to help improve safety when they're performing activities such as bathing, dressing, and other self-care activities. We can continue. Thank you. So I just wanted to talk about fall prevention a little bit. We definitely, want to be able to do these assessments, these full evaluations for patients. So we're identifying all of the factors that may be impacting them, but some quick wins your teams may be able to implement during an encounter include discussing with the patient and family, removing trip hazards such as throw rugs, or helping provide assistance with decluttering their environment and opening up those walkway areas. Identifying and educating the patient and the family about slip hazards, such as areas in the kitchen or bathroom, which may frequently have wet surfaces, and how they can help to keep those a bit drier and prevent slips. And then also identifying and educating patients and families about proper use of assistive devices that might be available, such as canes or walkers in the home. Canes should be used on the patient's strong side, and walkers, most frequently misuse of walkers involves the patient pushing the walker out too far. We still want them to keep it close to them where their arms are not fully extended. It's close, they can lean over and then take that step. If they get it too far out in front of them, it increases their risk of tripping and falling. We can go to the next. All right. We value every opportunity to collaborate with our partners. Patients with wounds or complex conditions often need mobility equipment, and they experience fragmented care, which can result in delays and increased risk of morbidity and mortality as a result of falls. Our coordinated mobile and telehealth care integrates Restore First Health services with telehealth clinical evals to help ensure that patients receive necessary equipment and care seamlessly and efficiently. And it results in faster equipment approvals, decreased administrative burden to our partners' teams, together that require documentation that Kim mentioned earlier, and better coordinated care at home, all resulting in meeting our patients' needs in a faster, more streamlined manner. Continue. Get you back to
Guys,
Kim
since
on.
2020, we've been trying to find the mute button, and I just lost it again. I'm so sorry. It's 2026, and I'm still losing the mute button. All right. So you guys, this little flow here, I'd say for the RFH team members, just earmuffs for a quick second. Your process is going to look a little bit different, right? But for those of you that are not employees of Restore First Health, this will give you a quick snapshot of our process overall. I know a couple of you have asked that already, how does this work? So step one, there's an account on our portal. Our team will educate your team members ahead of time and ensure that you're able to navigate through our portal. You'll create an account, and you'll receive an email from our friends at Atlas, who is our EHR. Now, once you do that, you're able to add a patient pretty easily, and we will walk you through that. We'll schedule a training with your team following this if there's interest. But there's a few things that we need to have, and a lot of companies, partners that refer to us initially when they first reach out, they'll say, "Why do I need to give you all of these medical records? I send a referral to a therapist, and the therapist, I can send the patient's name and date of birth and phone number, and that's all we have to do," right? Because we're doing both that physician face-to-face along with the therapy eval together, we need a bit more information, a little bit more background on the patient, so that our clinicians like Amber are able to get through that evaluation a little bit quicker because we've got some background on that patient. So we require medical records on every patient that's sent over to us. So a face sheet, medical records, and then a same or similar, right? So for those of you who are not familiar with this, what a same or similar is, it is and every insurance company calls it something different, but it's essentially proof of prior equipment. So if the patient is already in a device, you'll upload information for us so we know what device they're in. Again, that helps Amber and our therapist, in the background, ensure that when she's evaluating the patient, she has an idea of, okay, what exactly does this patient have now, and how can we improve that patient's quality of care as appropriate. Once you upload those documents, you are able to access our clinicians' calendars and schedule right from our portal. So you were able to, coordinate with an ATP and ensure that the patient's available. You've got access to that. The evals typically, they're all scheduled for 45 minutes. Some can end a little bit before that, just depending on how much information our clinicians have ahead of time. And then we always encourage that any of our partners that are referring, many of them have texts that they send in to the home to be with the patient while we do our eval. So we can coordinate all of that if there's interest following this presentation. The final thing I want to touch on, and this is for everyone, if you'll click one more time for me, Lori, the documentation. I mentioned this earlier, but for those of you who are late joining us, we're able to get both face-to-face and therapy mobility evaluation notes in 2 business days. And that is far below the industry standard. And there's less coordination that takes place. So we can, again, if there's interest from your teams, we're happy to schedule a training. You can go to the next slide, Lori. Now, RFH friends, you can take the earmuffs off now. For those of you who have patients that may need a mobility assessment, your clinical leadership is going to run through this process at your clinical meeting on March 9th. An invite should be coming out soon if it hasn't been sent out yet. So just kind of tentatively mark your calendar, or put a hold on your calendar for that. If you have a patient in need of an assessment before then, if you go to assessment and plan in Athena, for those of you who are on Athena, you'll go into assessment and plan and keep an eye on the screenshot. You can follow that. It'll help you. Your clinical lead will also be able to help you if there's questions before then, but just know you'll have that entire process ironed out and presented to you on March 9th at 4:30 Eastern. You can go to the next slide. For those, and I think I think I got my slides a little jumbled up. For those of you that are not at RFH, if you want to scan the QR code on the screen, it'll take you to our website for you to get additional information. If you're anything like me, you will hop off this meeting, another squirrel will pop up, or there will be some sort of distraction, and you will forget to follow up with us on this. We're excited about being able to perform these fall risk assessments with patients via telehealth. And it's something new for us, again, because of the work that's been done at telehealth clinical evals in the last year, and even the 4 to 5 years prior, when the company got its start. We've learned a lot throughout this time. And as we've learned, we want to be able to, we've seen the benefit, essentially, just the benefit of having these visits be telehealth, but still having the visit in telehealth not compromising clinical quality, right? That's our number one goal. Can you have a telehealth visit and not compromise clinical quality? So yeah, please, for those of you who are outside of RFH, please take a quick scan of that QR code. I'm continuing to talk just to give you extra time to get your camera out and scan the QR code. Lori's over. She's like, let's go, let's go. No, go ahead. You can go to the next slide. No worries. All right. This is for Amber.
Thanks, Kev. I think we've covered a good portion of this, but just to kind of bring it all back together, we work every day to make a difference for our patients. And we really, our goal is to provide smooth, efficient workflows for our patients and our partners to streamline our document management and collaboration with our partners, resulting in faster approval and equipment delivery. Our processes are really focused on reducing delays and denials and improving care collaboration to ensure that our patients' needs are met in a timely manner. I will just add that we do sometimes have very complex patients, and so we'll sometimes hold documentation when we're working with our assistive technology professional, so that they can work with the patient and then do some additional assessments to make sure that we're providing all of the appropriate equipment to make sure that they're safe, they're properly positioned, and that their skin is appropriately protected. I think we're ready for Q&A, guys.
We are, and I think there are a couple in the chat already, but Lori, I don't know if you want to.
So thank you both, first of all, for a very comprehensive overview. We all appreciate that so much. Great information. There's a couple things in the chat here. So, and if you have more, you can go into the Q&A and go ahead and ask your question. But let's start with Jackie, who comes from Specialty Medical Products. She said, which equipment companies do you work with?
Awesome. And thanks, Jackie, for getting your information in there. Guys, I just asked Jackie to throw in her contact info. So please don't spam her. Please don't text her. This is actually for Amber and I. But thank you, Jackie, for that. So the companies that we actually work with quite a few different companies nationally. So we're actually in 13 states. We work with a lot of the major players, right? So the NSMs, the New Motions, the Rehab Medicals, Hover Rounds, it varies by state. So, if you are needing an introduction or you have patients that are in need and we need to bridge the gap for you, like Jackie will definitely reach out to you after this. We'll schedule some time and just kind of talk through opportunities and then connect as needed. If there's a company that you work with, obviously I just mentioned kind of the, larger partners nationally, but if there's a partner that you work with that you'd like for us to connect with, we're happy to do that. And just so we're all on the same page and rowing in the same direction, we'd love to schedule that.
Awesome. And
Next, go ahead.
Asked, do you use Parachute Health?
We do not. And I feel like in a previous life, I don't remember what Parachute Health does, but I know I've heard
DME billing, Kim, but we don't bill for DME directly through TCE at this particular stage, because we're not buying the equipment and reselling it. So we're referring off to equipment providers. So Parachute hasn't made it to the top of the pipeline yet, but it's a great app, and we probably should consider it for some of the future initiatives that we've got.
Awesome. Thank you. I could not remember to save my life.
So we can help with that too. We use it. We do use it for some things. Yep. So we can certainly help.
Thanks, Pierre.
Okay. Awesome. Then we'll definitely connect on that offline. And then for those of you that maybe did not want to type questions into the Q&A portion, feel free to hop off mute if there are any questions for us, thoughts, concerns, anything that seemed odd or you'd like clarity on. And if we've wowed you, you can just let us know we've wowed you in this presentation.
So Kim, it's John. How are you?
Hey, good. How are you?
I think you guys live in this all day, every day, and I think what gets lost is the benefit to the patient and benefit to either a manufacturer, supplier, or a physician that wants this done for their patients. I think you kind of glossed over, why does it take so long if I need a complex, wheelchair to get that done without the service that you guys offer? So why does it take so long?
Yeah,
Sure,
I
no,
can
good.
take that.
Go for it.
So I actually, in a former life, if you will, worked in a pediatric complex care clinic, and all of our patients were patients who, pediatric patients who were technology dependent. And so what our process was, and what the process is for so many of our outpatient physician provider partners, is you start with the order saying the patient needs a wheelchair, the patient needs a power wheelchair. You send that to a mobility company, whatever company the patient prefers. It goes through the mobility company, then the mobility company sends a fax back, or through your EMR system, and says, oh, well, we need a full face-to-face document. And so then that has to be taken and go through medical records to then send it out to the mobility company. Then it's the same process to get an OT or PT evaluation. And just speaking to the pediatric world, it could take 10 to 12 months to get that patient in for a specialty evaluation. It's the same in adult care, that there are delays because these are very specialized clinics for wheelchair clinics. And so it can take months to be able to get an appointment. On top of that, there's a time frame from the time that the physician does their evaluation and initiates that first order. There's a time limit from when all of that documentation from the OT or PT can be pulled together and that order can be submitted to the insurance company. And if that's not done within that 6 month time frame, I think it's 6 months, then you start the process all over again. Once those are done, then the mobility company gets that information, puts an order together, and then they send it back via fax or however, and you go through that administrative burden of gathering all of that documentation, getting the provider to review and sign off on it, and then being able to send it back. So that's where kind of all of the steps can result in delay.
Exhausting just thinking about all of those steps, you guys. Like, I would say the other thing to touch on is a good example of this is like an MS patient, right? An MS patient can present very differently from day to day. So because, like, to answer your question, John, because we've got two people in the eval seeing the patient at the same time in that same condition, that speeds things up. When we, in the traditional route, that patient could have seen their PCP on a good day and the therapist on a horrible day, or vice versa. And so their clinical documents don't match up. Then Medicare or whatever payer, reviews that document and says, wait a minute, this doesn't even sound like the same patient, because the same visit, their two visits were done separately on different days when the patient presented differently. So us having both on the same eval along with the ATP and kind of communicating through that, it really shortens the time. So yeah, good question.
Thanks for answering. By the way, I have one more thing I just want to say for the fall risk assessments for the Restore First Health members that are on this call. And by the way, thank you guys for this. We deal with at-home patients, so my assumption is almost everybody would need a fall risk assessment because our patients are low to no mobility. And of course, we have a few patients that are fine, just happen to have a wound that can get up and walk around. But I would argue that majority of our patients should do this, and we should be doing this because we care about our patients, right? If there's an issue and all they need is a little walker or a cane, and they're not getting it because nobody even brought it up to them, I think it's incumbent upon us to make sure our patients are safe in their home so they're not falling. We want to keep them at home. We don't want them to go to the emergency department. We already know the cost part, but just the patient is getting kind of lost in the shuffle sometimes. we're in, we're out, home health is in or out, but is anybody kind of taking charge of this? So I would encourage, and I'll leave this up to Dr. Bromley and Dr. Phillips, but I would encourage, our nurse practitioners who are in the field to take note and refer the fall risk assessment over to TCE. I mean, that just makes sense to me. And, what do I know? But I just figured it would make sense for that to happen. So thanks, guys. I really appreciate it.
Thank you. Dr. Bromley has a question. His hand is up. On mute, Dr.
Without
Bromley.
muting. Yeah, I know. So again, congratulate Kim and Amber on well done. And I would say to everyone on this call, one of the things that we've been really focused on at Restore First is to not get target focused on the chief complaint. Really, we really want a head to toe assessment of every patient that comes into our care, because doing so really is best practice. And fall risk is a massive risk factor, not only the patient, but also for our referral partners. If we're getting a patient from a hospital, one of the high risk is that patient's going to go back to the hospital for readmission, and they're not going to get paid. So if you're seeing a wound patient or seeing a patient with lymphedema, it is incumbent upon you, and I beg you, please always think about the patient. Look for those fall risks. Use the tools at your disposal. Use our resources as medical advisors to help you whenever we can, because that's just it's our responsibility. And fall risk is something that, even as a physician in my own practice, is one of those things that sometimes it takes just an extra minute or extra few minutes to be able to educate and take action and get help when we need it. So feel free to ask for that help from our TCE partners as well as us within RFH. Thank you.
Thank you. Any last questions? All right. Well, everyone will get a follow-up email, and this webcast will be reposted for the RFH team. It will be on the Insider as always. And for our partners in care, it will be out on our social channels and our website as well for any recaps or information that you would be looking for. So we thank everyone. Amber and Kim, thank you so much for working with us to put this presentation together and to make it comprehensive for both internal and our external stakeholders who are so passionately caring for all the patients that are at home and struggling with mobility and struggling to just find hope in their care. So thank you to you all, and have a great day.